So, respected chairpersons and all respected seniors and colleagues, I am Dr. Devang Patel, those who don't know me, and I am going to talk on menopause. We are going from one orifice to other orifice. So, the thing is, menopause, what is our storyline? See, why we are choosing this topic, what are the effects on various systems, and how do we manage it? Now, why menopause? Because the life expectancy has increased, and we see many ladies in this phase of life, and it is often neglected, and it is seen that it is being told by family and friends that it is part of life, and you have to go through it. You can't do anything for it. You have to just go through it. So. We had a World Menopause Day on 18th of October, just few days back, and this is the main purpose to sensitize everyone for this topic and to sensitize our patients also for this and how they can take care of them in this phase of life. Now, what is menopause? Menopause is nothing but time of cessation of ovarian function leading to permanent amenorrhea. Okay. Now, I would just like to ask, anyone can answer. Suppose a lady with 47 years of age and coming with 3 months of amenorrhea. Would you call this a menopause or not? Why? 1 year. 1 year. So the answer is 1 year. So it's always a retrospective diagnosis. Okay, you cannot diagnose in OPD. It has to be 1 year. And any bleeding per vagina which is occurring after 1 year of amenorrhea is significant. It is called postmenopausal bleeding, and it has always to be investigated. It is not to be ignored. Now, generally, this menopause comes with the age of 45 to 55 years. If it comes before the age of 40 years, it is called premature menopause or premature ovarian insufficiency, and it requires special care because there is a long duration with this hormone deficient state. If it comes after the age of 52, then it is called late menopause, and it is seen mainly in ladies who take good care of their health and who have good nutrition backup. Now, what are the symptoms? The patient will give કે ગરમી લાગે છે કે એસી ના નીચે બેઠા છે તો ગરમી લાગે છે, પરસેવો છૂટી જાય છે. So this is typical what patient will give in this phase, and it is called hot flushes. It is seen by 70% of the cases. Vaginal dryness, low mood, feeling of anxiousness in very trivial matter, joint and muscle pain, decreased libido, and urethral syndrome is also there. Now, when this continues for many years, you will see the changes of osteoporosis, which we can diagnose by DEXA scan. Then ischemic heart disease is increased because estrogen will decrease. Estrogen will increase the HDL and decrease the LDL. And when there is deficient state, then it is going to decrease the HDL and lead to all these disorders. Stroke, Alzheimer's disease, and various eye problems are also seen with this. Now, how do we manage it? So, the good part is 70% of these cases will be managed by lifestyle modification, dietary modification, and very few supplements only. Very few require hormone replacement therapy. And as we know, lifestyle modifications, you ask the patient to go for a regular aerobic exercise, running, walking, swimming, low intensity exercise, yoga, meditation, and reduce the intake of caffeine and alcohol if applicable. In dietary supplements, you should always take what are the dietary habits, what is she taking, what is she not taking, and always ask her to take at least 1.2 grams of calcium per day. And in that case, what you can do is, if that much dietary supplements are not going, then always you can give calcium supplementation. Vitamin A, C, D, and E, they are useful as antioxidants and very helpful. One of the most important dietary supplements in our case is the soya beans. It is high in proteins. It also contains isoflavones, which mimics the estrogen activity, and it is a plant non-steroidal product. So it is very useful, and it is gained from diet only. So you can always ask your patient to take this soya beans. Okay. And bisphosphonates are the one which can be used after the age of 60 years for osteoporosis. Earlier, hormone replacement therapy is also there. Various herbal medicines and alternative therapy may also help in mild cases. But the ultimate answer is hormone replacement therapy. Now this sounds the best treatment, because if hormone is not there, we are going to replace it. But it has its own advantages and disadvantages, and in which patient you should use it. Suppose the symptoms are not relieved by all the previous slide treatment, then you should go for hormone replacement therapy. Someone who are at high risk for having a high cardiovascular disease, osteoporosis, someone who is having premature menopause, that is around the age of 40, menopause by chemotherapy or radiotherapy, and gonadal dysgenesis in adolescent. What are the contraindications? If the patient is having breast cancer, uterine cancer, or family history of these cancers, previous history of thromboembolic episode, liver and gallbladder disease, or uterine fibroids, because if you give hormones in this, the fibroids may grow in size. And its uses are mainly short term and long term. Short term is like 3 to 6 months, and long term may go up to 8 to 10 years. So what I'm trying to say is that it is not that hormone replacement therapy should be used for very shortest possible. Yes, shortest possible, but it should be used when it is indicated. It should not be denied to any patient. And what are the drugs? Mainly, see, estrogen is used because all the symptoms which are occurring are because of the estrogen deficiency state. Now, we replace estrogen. What estrogen? Primarin is the one which is being used. It is conjugated equine estrogen, 0.65 mg to 1.25 mg. Then others is Evalon, ethinyl estradiol is being used. And we also use progesterone along with estrogen. Now, can anyone tell me why we use progesterone? Exactly. So the thing is, if you give unopposed estrogen, that will cause endometrial hyperplasia and may lead to endometrial carcinoma. So progesterone always has to be added. Now, other thing is, when we give this after menopause in a cyclical manner, the patient may have bleeding, and sometimes patient may not like it. So what we give is a continuous HRT, means the estrogen and progesterone is being continued daily and not stop. Oral and local. Now, oral has one disadvantage is that it is because of the liver bypass, only 10% reaches to the systemic circulation, while local has a better bioavailability and less side effect. But in cardiovascular disease prevention, oral is better than the local one. Local estrogen cream is mainly used for vaginal atrophy dyspareunia and is used at dose of 1 to 2 grams daily for 10 to 12 days for 3 to 6 months. And long-term therapy is basically 8 to 10 years, and in which there are various options of oral. Transdermal patch is also there, which has to be changed twice weekly. Gel is also there, and implant, which is used in Western countries more, in which there is a minor surgery, but it lasts for 6 months and there is no other headache of taking daily medicines. So I would like to end with the theme of bone health, which was told in this World Menopause Day, to sensitize our patients for better bone health by walking, taking calcium supplementations, and thereby reducing the vertebral and non-vertebral fractures. Thank you.